Welcome, everyone. Good afternoon, and welcome to the Innovative Discovery Series this afternoon, brought to you by ACCEL, Delaware Center for Clinical and Translational Research, and Christianis Care's Institute for Research on Equity and Community Health. Before we get started, a few announcements. So first, mark your calendars for March 9th, when Emily Kaufman of the United Way is going to be speaking to us about the Equity Counts Data Center and Partnership Initiative, building data capacity with community-based organizations in Delaware. So again, that is March 9th. If you're in need of continuing education credits for this talk, please reach out to Deborah Reese. She will place her email in the chat box. I think she already has. So reach out to Deborah in the chat box. And now on to the main event. We are delighted this afternoon to introduce Dr. Frank Curriero. Oh God, sorry, Frank. Curriero. Dr. Curriero is a professor in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. He's also a trained statistician who works at the intersection of epidemiology and biostatistics within a wide range of public health applications. Frank's research focuses its expertise in the development and advancement of spatial science methodology, including components of spatial data, geographical information systems, and spatial statistics. He also leads the spatial analysis curriculum at Johns Hopkins, both on-site and online, and is the founding director of the Johns Hopkins Spatial Science for Public Health Center. He continues to focus on the importance of understanding how where we live, work, and play impacts every aspect of our health. And not only has Dr. Curriero guided work within our ACCEL program and within iReach, he's also been a mentor and collaborator of mine since my days as a doctoral student in epidemiology at Johns Hopkins, nearly, and I was calculating this afternoon, almost 20 years ago.
Ooh.
So although I look a bit older, he definitely has not aged.
Yeah, no, I think the other way around with that one.
This afternoon, we are truly delighted for him to speak to us about harnessing the power of geography in public health, spatial case study reviews from our own state here in Delaware. Take it away, Frank.
Thank you so much for that introduction, Mia, and always wonderful to see you again outside of the academic setting. So, like Mia said, I've been involved in this field probably before about 20 plus years at least. And through that time, in terms of teaching and research and working with colleagues and so forth, we've come to develop what we call the spatial science paradigm, and it's got three primary components. And this is something that has certainly evolved over time. So it's got components of spatial data, GIS, and spatial statistics. And I'll keep some things simple, at least for this first slide. Spatial data, what we mean by that is just data that's tagged with location information. And the technologies nowadays, in the last 5, 10, 15 years has really expanded our ability to collect and like you hear me talk about, harness that information in a lot of what we do. So there's a spatial data component to spatial science. There's a GIS. It stands for Geographic Information System. That's our software for making maps. And it's also really great at integrating spatial data from different sources, linking it all together spatially, and making a map. And the primary output of a GIS is that map. And then we lean towards this field of spatial statistics to allow us, in a sense, to go beyond the map, to actually analyze the trends in that map and apply statistics to that map data. And pretty much the rationale that we've come across over these 20 plus years working in this field is that everything that we study, all our identified health outcomes, measured environmental determinants, whether it's behaviors or different types of environment, all this data, all these phenomena that we study, everything varies spatially. So the idea, the motive is to collect and harness this information to basically improve everything we do. Starting from the very basics of study design to some of the analysis, which is I'll focus on today, and then obviously to what that analysis is feeding into: prevention, intervention, control, policy efforts, and so forth. So you can have a separate lecture on each of these components separately, and any of the details underneath each one for sure. I'm going to focus today on that last one on spatial statistics. And it's going to be focused with a lot of, I've been fortunate enough to have some collaborations with Christiana Care Health Systems. And so a lot of my focus will be, all of my focus will be in some of the Delaware studies that we've looked at. But I want to bring up this one other study first. And I apologize if people have seen me talk before. I usually bring this one up, so you might have seen this one. It's a great example of the power of spatial data in GIS. So this is a map of Zambia, not Delaware. So we're in southern Africa now, and it's the outline of a you can almost see the outline there of a residential township known as Lusaka, Zambia. And I titled this as doing spatial analysis in resource poor settings because not all areas of the world have available the information that we have. And this example is at least about 13 years old now, and it still stands the test of time of it greatly exemplifying the power of spatial data in GIS. So we start here, and how would you even start designing studies? If you wanted to enroll, in the study of this year was to map spatial variation and risk of measles susceptibility. So they needed to enroll children into a study, get take questionnaires of these children, get blood from these, do some assays and so forth. But how do you even start in this? So the way we started was we started with this satellite image. And we blew this satellite image up, and you see the blown up version on the right hand side. And then we did a process called digitizing, which is basically taking this remote sensed image, it's electronic, and you bring it into that software GIS, whether it's ArcPro or QGIS or one of the few of the other ones that are out there. ArcPro or ArcGIS is certainly the most powerful one. And then you take your cursor and you just go over one of these buildings and you click. And when you click, you get the latitude and longitude coordinate, which is a pretty powerful thing to do. I say it's like doing GPS without actually having to be there, because this was done based on an office in the Bloomberg School of Public Health. So that was an extremely powerful tool to utilize. And we did that, and we actually had a student do it, and it wound up being over 16,000, I think it was like 16,500 something different structures that were digitized. As a courtesy, my GIS colleague and I showed the student how to do the first 5, and then she took it away with the rest of that. And so those yellow dots are all the digitized structures. The blue dots are the ones that were just a random sample chosen to be in the study. And not only did we just digitize and get the latitude, longitude coordinates for these studies, but you can also see some of the boundaries around here because these maps were printed out and handed to what's known as community health workers, which were the professionals on the field that would go from house to house, try to enroll kids, get their data, and so forth. So the blue dots were the ones where they had to go and visit. So you actually not just digitized the structures, but we built this own geography, these certain areas that each community health worker would be given these maps to go and do it. So that's a great example of really emphasizing the power of spatial data in GIS, because we start with nothing and now we have an awful lot. And what was this able to lead us to? Well, we're able to go and enroll these people in a study and collect data. Now we have data. It's tagged with location. You see these red and blue dot maps on there. You'll hear me say something about red and blue dot maps a lot today. So these are just, the first map is just a map of kids that are enrolled in the study that are and are not susceptible to measles. And then the second red and blue dot map is ones that have HIV antibodies and not. And so we kind of analyze this data, and you see some heat maps there. I'll talk about what those are, but basically we were looking at does there overlap in terms of measles susceptibility and HIV antibodies. What was nice with this, we got 2 nice publications, or the student, Sarah Lother, got 2 nice publications out of this sampling, this satellite-based sampling method was published in Trout Medicine and International Health, and then the actual follow-up analysis was published in the Lancet, which is probably one of the premier public health journals, and it just kind of exemplifies the power of spatial data in GIS. And so I just always want to bring up that example. But I want to focus on my collaborations with Christiana Care Health System and focus on data and projects in the state of Delaware. So I am very fortunate to have had and continue to have very rich collaborations with Christiana Care. And I just want to acknowledge some of my colleagues, so Scott Ziegel, Maddie Brooks, Pregain Canal, Alicia Salvatore, Yu Chen Zhang, and of course Mia Pappas for bringing us all together and keeping us all together. And so I'm very thankful. This has turned out for me personally probably one of my more favorite collaborative efforts because it includes a lot. It includes us introducing and building capacity in spatial science, so spatial data, GIS, spatial statistics. Working with some great, more seasoned scientists at Christiana Care that are experts in the substantive context and are open to bringing in spatial tools, and together we help interpret the results of that within the context of those studies. And it also has some younger scientists that we're able to mentor in spatial analysis and teach of these skills and let them go and refine those skills. So I'm fortunate for that. So thank you, Mia, for keeping that alive. So anyway, our focus is going to be in Delaware, mostly in Newcastle County, which I asked before this talk, is everybody from Delaware? And they said yes, so everybody knows Newcastle County is the northernmost county. So we have data from Christiana Care Health Hospital Systems, okay, and some publicly available sources that I will talk throughout. So I'm going to focus the rest of the talk on more of the spatial statistics stuff. So I'm going to kind of go through this from a statistician's perspective, where I'm going to show you the data we have, talk about the questions we want to answer, and then get right to how we answer those questions or how we addressed some of those questions. And I'm going to talk much less about the substantive context that a lot of this falls within, mainly because that's not my areas of expertise. But if any of my colleagues are on the call and we get questions about the substantive context, you're more than welcome to chime in and save me in that respect. So here's one project that I was working on. This is smoking and tobacco retail exposure. So the data we have for this is a little over 10,000 adult residents who were visiting the two hospitals in the Christiana Care Health System, the Newark and the Wilmington hospitals, between 2018 and 2019. And as they came into the hospital, they were, these are just the ones that had the history of smoking, and they were surveyed to whether or not they're a current smoker or former smoker. So that's the data we have. And we actually have, I don't have, but Christiana and some of my Christiana Care colleagues have address level data information for those. And I'll talk about how we use that point level data in some analyses. We also got tobacco retail outlet locations. This was obtained from the Division of Revenue, the Delaware Division of Revenue, as of April 17th, 2019. So I have 642 locations of tobacco retail outlets. We also have census tract geography, census variables as we need, and so forth. So the objectives one of the objectives that we're going to walk through today for this data set was to characterize the spatial distribution and what we call spatial interaction between smokers and tobacco retailers. So when I say characterize the spatial distribution, that's more of an exploratory sense. And just like if you're giving any data set, one of the first things you do is do a histogram, calculate, measures of central tendency, mean, median, variation, that kind of stuff. So there's similar stuff we can do with that, but in the spatial setting, and that's what I want to focus on today. And I'll define what I mean by spatial interaction as we get to that part of the study. I'm always going to talk about both aggregate and point level methods. And by point level methods, I refer back to the address level information. So we have the dot on the map where these people live. And we can use that information or do analysis at that level, or we can aggregate the data up. And by aggregating up, we mean looking at possibly census tract level summaries of data. And what was really nice about this project is at least from a statistician's perspective, we got two nice results that we were able to publish on. One was sort of a novel method for looking at the clustering of one event type around another event type, and I'll talk to you about that in the coming slides. So that was a novel application, and we also developed methods for improved choropleth mapping. So maps are going to be a big part of this talk, as you can imagine, and a chloropleth map. So what is a chloropleth map? Well, you see this on the right hand side. A chloropleth map is when I have data aggregated to some area unit. In this case, I'm showing you census tracts in Newcastle County, and then we have some kind of color shading, that shows you the level of that outcome or that value. That's a choropleth map. Okay, and it's likely the most popular type of map in and outside of the public health arena. A lot of times, this is just the map that is shown in newspapers and other reports. And so in this case, I have data, and I'll talk about what that data is, but it's aggregated to the census tract. So you see I think it's about 129 census tracts within Newcastle County. The map on the left, okay, that's a map of the ratio of current to former smokers. So we actually have the dots on the map. I don't have the dots, and even if I did, I couldn't show you those dots. And that's one reason why we aggregate data and do choropleth mapping, is because sometimes you can't show the dots. There's confidentiality and disclosure obviously is one of the big reasons that we aggregate data and map data via like choropleth type maps. So on the left hand side, we have the ratio of the number of current smokers per census tract to the corresponding number of former smokers per census tract, just to kind of give a rough estimate of risk. And you see the different categories there and the color shading. The map on the right hand side, what we have is the number of tobacco outlets, and it's per capita. So here it's per 1,000 adults. So it's like a rate of tobacco outlets, if you have your proportions, probably a better way to say that. And you can start looking at these maps side by side to kind of eyeball some spatial overlap. The idea, the premise is, wow, do I have more tobacco outlets per capita in areas where I have larger ratios of current to former smokers? And you can kind of try to make that assessment here by looking at these maps side by side. And each of these maps, a lot of times when I show these maps, Wilmington will be shown as an offset map, just kind of blown up a little bit more. But there's a tool in mapping called bivariate choropleth mapping, which I see a lot more in the geography literature, but less so in the public health literature. And it'd be great to have this type of map to be shown a little bit more in the public health arena. And what a bivariate choropleth map is pretty much saying what it is. It's looking at two variables, bivariate, at the same time or simultaneously. So here I'm showing you a bivariate choropleth map of one variable is the ratio of current to former smokers per tract, and the other is the number per capita of tobacco retailers per tract. And you can see, so here is sort of the legend down here. It's a diamond. It goes from low to high, and then it stands out in that diamond face that's showing you different categories. So the categories for each variable is split into three: a low, medium, and a high. And you got the color schemes for all of those 9 different categories. Okay, and you can look at this and you can see some of the pictures here covering what the Wilmington offset, but you can see in Wilmington, that's where we really have high current to former smoker ratio, as well as high tobacco retailers per capita, and some other things that, high density of tobacco retailers in neighborhoods around the 2 Christiana Care hospitals. We're not saying Christiana Care hospitals is an attractor to tobacco outlets. It's more likely due to population density and retailer density as a whole. But this idea of a bivariate choropleth map is kind of a neat way to map things, aggregate data that's aggregated to census tracts, in one map, as opposed to the 2 maps we saw on the previous slide. Sometimes it gets criticized as being too busy, right? Because here I just put into 3 categories, and I have got 9 total colors to look at. Sometimes you see 4 categories, like in quartiles, and then you would have 16. And I agree, that gets to be a much. A lot of times we're just interested in the extremes, maybe the low, the high, the low, high, or the high, high. And in that case, you can still split it up into these 3 categories, but then maybe take these moderate categories. So the one there, So the one there, the three there, and the three along here, and gray them out, make them all one color. So you just have four colors for the bivariate extremes, and then one color for the moderate categories to kind of take a little tension off the number of colors to look at. So that's certainly a popular way to look at bivariate associations simultaneously in one map. But we have the point level data, both not only for the tobacco retailers, but also for the current and former smokers. So I want to talk to you now about some methods that we can do dealing with the point level data. And on the right-hand side, you see a map. These are the points of the tobacco retailers. Perfectly fine showing you that that's publicly available data. So that's the map of the 642 tobacco retailers. I have them coded there as red and blue, based on how close they are to a track boundary. Don't worry about that. I'll bring that up again later on. But there's a method called spatial intensity, right? And spatial intensity is defined as the expected number of events per unit area. This is what the formula looks like. Sometimes people that are familiar with this, you might read in the literature, it's called the KDE approach because it's based on a kernel density estimation approach. That formula looks maybe a little complicated, a little foreign to maybe a lot of us, some of us. I'm not going to talk about that formula, but I'm going to try to tell you what this kernel density estimation is doing, okay? And basically, a lot of people have seen a histogram before, and a lot of times nowadays, at least when histograms are produced, sometimes you'll get the actual curve above it, like an estimated curve above that histogram, whether it's bell-shaped or skewed one way or the other. But that curve that sometimes you see added on top of the histogram or over on top of the histogram, that's likely based on a kernel density estimation. It's kind of smoothing out that histogram. And this spatial version of that is doing the same thing, but in the spatial setting. I have two dimensions now, east and west, so I have to grab data from around each location and kind of smooth that out. The product of the map, the product of a spatial intensity estimate is showing the spatial variation in the concentration of events. You can see that by the dot map on the right. You can see where these tobacco outlets are concentrated more. Okay, there's only 640 of these. Imagine if we put down the 10,000 dots of the current and former smokers. Okay, it gets a lot busier. So this kernel density estimation is a way to smooth that out and see it a little bit, kind of reduce some of the noise and just see the actual trends. So here is the output of a kernel density estimation. You see that over on the right-hand side. So we start out with the dot map, the one on the left, and then we apply kernel density estimation. And this is an output from that. So now you can see sort of what's sometimes referred to as a heat map, right? It's showing the spatial variation in the concentration of tobacco retailers. And this is a little easier on the eyes to interpret, to present, and to communicate. Another thing is this kind of map can always be published in the literature. Whereas if the dot map can't be, for example, if we did the spatial intensity of the current and former smokers, which I'll show you later on, we can't show those dots. Okay, so to do a map, keeping the analysis at the point level, we're able to show an intensity of the map rather than showing what the dot map might look like. Here we're dealing with tobacco retailers, so it's not that big of a deal. To give you sort of I'll call it a layperson's interpretation of what spatial intensity is actually doing. I'll give you an analogy here, and I just want to clarify that I did not come up with this analogy, although I do kind of like it, but it's kind of out there. Imagine you had this map, the map of tobacco retailers, and you were able to blow this up and print it out in a little bit bigger than 8.5 by 11. So you've got this map on your desk of all those dots. Take a small piece of chocolate, and again, I told you this example is a little bit out there. Take a small square piece of chocolate and put it on top of each of those dots. Right? So if you had 642, you'd put it on each one of those dots. Or if you had 10,000, you'd have to have 10,000 plus little pieces of chocolate. And you put that on there on the map. And obviously, these points are going to be close together. Some of them are going to be close together. You can see that here with the dot map. So those pieces of chocolate start piling up. Okay? And now what you do, and that piling up of the chocolate is analogous to your dot map. Now you take a hairdryer and start going over the map, just kind of uniformly over the map. I promise you, this was not my analogy I came up with. And what will happen? The chocolate starts to melt, right, and starts to disperse. That's what intensity is doing. That's what you're estimating. That's what you see over here on the right-hand side is that melting of the chocolate. And you could think about, we talk about levels of smoothing, right? Because that's a smooth version on the right-hand side. Okay, so how long you keep that hair dryer there, that's your level of smoothing. Okay, if you keep it there, everything, all the chocolate's going to melt. Okay, but you just do it enough sort of just to get a nice looking picture of the spatial variation in the concentration of events. The key thing to remember is as you're doing that smoothing with that hair dryer, the amount of chocolate has never changed. It's always there. So it's always representing 642, in this example, tobacco retail outlets. It's just that you've kind of smoothed that mass or dispersed that mass, so you can get a better picture of the spatial variation in the concentration of events. And you can compare, well, so what I want to do now, sorry, I was jumping ahead a little bit. What I want to do now is talk about taking that spatial intensity and actually applying it to the current and former smokers. So I have a dot map of, let's say, red dots for the current smokers and blue dots for the former smokers. I can put them on the same map. Okay, and now let me apply spatial intensity to each one of those variables. So I'll generate two intensities, one for the current smokers and one for the former smokers. And then think about taking the ratio of those intensities. We call that a spatial odds. It's like a non-parametric estimate of the spatial variation in risk. At every location, I'm estimating the expected number of current smokers per unit area divided by the expected number of former smokers per unit area. Okay, we did that with the current and former smokers, and that's what you see on the right-hand side. So now I can't show you the dots of the current and former smokers. I don't even have them. But this is a map that we can present, and it's a spatial odds. It's a non-parametric in the sense that we did not we did not assume any statistical distributions for this data, just using the data to estimate this kernel density intensity. And that's what you see on the right-hand side. So you can see areas where I have elevated risk, elevated expected numbers of current relative to former smokers, obviously in the Wilmington area. And then you can see this pattern that stretches a lot down here. People that are more familiar with Newcastle County and that would understand that a lot of the health outcomes we study shows areas of increase in tendency right along this corridor here. So that's what we did with spatial intensity. We plotted to both the current and former smokers, and you could look at the sort of the effect of aggregation in this. So imagine a point map of current and former smokers, the red and blue dots, right? That obviously we can't show, but one way to do is aggregate everything to the census tract and then maybe take a ratio at the census tract level, like we showed already. That's the left-hand map, or the right-hand map now is a ratio of the intensities. So you can see they might line up in some areas, like in Wilmington, they line up. But how much of this corridor did we able to pick up with the aggregated data versus the non-aggregated data? We have sort of what might look like some areas of elevated risk in the very southern parts of Newcastle County, but that doesn't show up on the aggregated data because the census tracts are bigger down there. So I'm aggregating more. So that is an example of using spatial intensity, and this is how we use it in some of our studies for the smoking study. Intensity is one way to characterize the spatial distribution of data. It's sort of getting at in statistics what we call the first order moments. It's the mean of the process. Where are the data? How many do I have? And what's the spatial variation in the concentration? Going to a second moment of a statistical distribution, we talk about variability and variance. And in the spatial setting, we talk mostly about spatial dependence. Okay, and spatial dependence is broadly defined as observations closer together are more similar than observations further away. And when you map things, you think that okay, dots closer together are more similar than dots further away. But we're dealing with dots. I don't have a value. It's not that type of data. So when we have the dots on the map, we talk about clustering. Okay, are the dots closer together than they should be, or than they would be if they were just randomly thrown down there? So if you wanted to theoretically define what we mean by spatial dependence for event data, these are dots on the map. It would be, if I know an event occurred at one location, I'm likely to get another one nearby. Okay, and that kind of exhibits itself as what we call spatial clustering. The dots seem to be closer together than if they were just thrown down there at random. So there is a function in our spatial statistics toolbox called the K function, which is a way to measure spatial clustering for this point level data. It assesses how close events are to other events, and it's a complement to intensity. So anytime I'm characterizing the spatial distribution of whatever, if I'm dealing with the point pattern, I would do an intensity map and a K function map. So here is the definition of the K function. The primary component in the definition of the K function is the expected number of events within distance h of an arbitrary event. So imagine going to every event, every smoker on the map, or every tobacco outlet on the map, and saying, well, what are the expected number of other events within various distances, within a tenth of a mile, 2/10 of a mile, a quarter mile, a half a mile, and do this for a bunch of distances h. And then we plot this, okay, as a function of distance. So intensity, the product was a map, that heat map. The product of the K function is actually a plot. Okay, and I'm going to show you a plot over here on the right-hand side. This is what a K function plot would look like. Okay, it has on the x-axis distance, right, because that's the varying distance, that's K of h, right? And on the y-axis is the K function. Not actually the K function in this one, so let me talk to you about what that is. The dark line here is what the K function would look like. So we estimate the K function, but there's a lot of other stuff going on that right-hand plot. So let me kind of walk through what that is. So what we did was we applied the K function both to the current smokers, the red dots on the map, and to the former smokers, the blue dots on the map. So I've got two K functions. Okay, and we're trying to ask the question, do current smokers cluster more? Are they more spatially compact, closer together to each other than maybe former smokers? But both current and former smokers, they likely cluster overall just based on population density, right? These are just, people of the general population. So where I have more population density, yeah, I'm going to have more current and more former smokers. Okay, so what we did was talked about taking the difference in K functions. And this is a common thing when I'm dealing with like spatial case control data, where I have cases of disease and a set of controls. But it could also be of any events that are labeled of two different types, here, current and former smokers. So we took the difference in K functions. Now, if they're both clustering at the same level, the difference in their K function for each H would be 0. So that's why I have the 0 line down there. Okay? But now we're taking the K function of the current smokers minus the K function of the former smokers. In words, I'm saying how tightly compact are the current smokers versus how tightly compact are the former smokers. And that black line is that estimated K function difference. It's greater than 0. So it tells me that, okay, well, the current smokers are clustering more than the former smokers. The current smokers tend to be closer to each other than the former smokers are to each other. Okay, that's why we talk about spatially compact. They seem more spatially compact, the current smokers, than the former smokers. The dotted red lines are our significance envelopes. Okay, and I have a footnote down there that significance is based on a random labeling scheme. If I had more time, I can talk to you a little bit about that. But let's be trustworthy that, okay, I have this way to measure uncertainty or measure significance, and you can see the solid dark line is not only above 0, the blue line, but it's above the significance line for up to about maybe 7 miles. Okay, so that's that level of clustering that it's significantly. So current smokers significantly cluster more than former smokers, up to about, looks like 7 miles. Okay, why would that be? That was an interesting finding we got. A lot of times if I'm dealing with case control data, like I have some kind of disease X and I'm looking at a set of controls, and the cases cluster more so than the controls, that's usually indicative of some kind of environmental feature out there that also varies spatially, that is kind of driving why the cases are closer together. But here we have current and former smokers. So why would we have the current smokers being closer together to each other than former smokers. To help us get at that question, we wanted to say, okay, what does the map look like of all the data we have? Okay, we have, so imagine this, because I can't show the map. So imagine a map of current smokers, we'll call those red dots. Former smokers, we'll call those blue dots. And tobacco retailers, we'll put them on the map too and call those black dots. I was able to show you the map of the tobacco retailers. Well, the K function is one type of clustering. There's another type of clustering, and this is called spatial interaction, where we talk about does one event type cluster around another event type. So do current smokers, do they cluster around former smokers, or do former smokers cluster around current smokers? That's a question you can ask. I don't know how interesting that is, but think about the tobacco retailers. Do current smokers cluster around tobacco retailers? That's an interesting question. We call that spatial interaction, where we have two types of events and looking at the clustering of one around the other. So there's a function called the cross K function. Okay, and the primary component in the cross K function is this expected value. Now, it's the expected number of type I events within distances h of type j events. And think about if I want to look at current smokers around tobacco outlets. We would say the expected number of current smokers within different distances of tobacco retailers. Back in the day, when I first got started at Hopkins, people were asking the question about does crime cluster around playgrounds? I think they probably still are asking that kind of question. And what they would do is they would draw different buffers of different sizes around the playgrounds, a quarter mile, a half a mile, 1 mile, and count the number of crimes in each of those buffers. This is what the K function is doing. Okay, so there is a tool out there to do that, and it's called the cross K function. So, but for our data, what we wanted to do was we want to apply the cross K function to the current smokers around tobacco outlets and former smokers around tobacco outlets. So, you could say, well, if the current smokers clustered around tobacco outlets, you could argue, well, maybe that's just due because, again, population density. Maybe that's where a lot of people are. But now I have the former smokers too. So let me calculate how much the former smokers cluster around the tobacco outlets, and then take that difference. In a similar analogy to how we took the difference in the K function to see if one was more spatially compact than the other, we can look to see, well, is one clustering more around tobacco outlets than the other? So do current smokers cluster around tobacco outlet retailers more than former smokers? That's what you see here, the difference in the cross K functions. So it looks just like the K function plot. I have distance on the x-axis. My y-axis now is the difference in this cross K function. So if they don't cluster more or less, they would be 0. But it's not. The solid dark line, which is our estimated difference in cross K function, is larger than 0. Okay? And here are my significance bands using, again, the same Monte Carlo random labeling scheme. It's significant. So do current smokers cluster around tobacco retailers more than former smokers? Yes, they do, significantly, up to about, ironically, like almost 7 miles. Okay, 7 to 8 miles. And so this was a very interesting finding. And the application of this difference in cross K function provided us an objective hypothesis test in a sense. And it was a novel application of using the cross K function, and something I haven't seen before. And Maddie Brooks actually took the lead on this one, and it was published 2 years ago in Health in Place. And it's actually a contribution, I think, to the spatial statistics literature, because it's really showing a novel application of these tools. Because a lot of times, you don't see K function stuff used much in the literature, unfortunately, in the public health literature. And this was taking something called the cross K function, which is you see even less, and then taking the difference between these two, because we had that data. We had the red dots, the blue dots, and then we had the fixed exposure outlet, that we wanted to see, and asking the question, do the red dots cluster more around the exposure than the blue dots? So very interesting work we did. And so now I want to switch gears. Again, I just want to talk about some of the statistics that we do. Obviously, we talk a lot about that so far, but still involved in this study. I want to talk about improved choropleth mapping. So how can we improve a choropleth map? Okay, here's a choropleth map of the tobacco outlets. These are just the counts now. It's not counts per capita. And so again, by census tract, I'm just counting up, so the white boxes are, 0 to 2 outlets, the higher up on the brown scale is 3 to 5 and so forth. I talked about a lot of times why we need to present maps in an aggregate form and do a choropleth map. Confidentiality and disclosure is certainly one of them. Tobacco outlets, it's publicly available data. We're not breaching any confidence by showing you the dot map. But obviously with the current and former smokers, we would. Also, another reason why people aggregate up, it's so we could reach out and use the census data for all our denominators. So if I only have cases of disease, I may want to aggregate up and do that. But there's limitations to this aggregation, and that is that it just basically counts the number of dots in each census tract and ignores how they may vary in that census tract. They may be all in one area of the census tract, and some of these census tracts are pretty big. They get smaller in higher populated areas by design, but even then they might be all along a certain area, so it ignores that variation and within the census tract. And one of my favorite census tracts, and my colleagues Scott Siegel and Maddie Brooks, if they're on the call, they'll probably chuckling because I always pick on this census tract there, this poor census tract here. But I pick it up, but look at this tract. This tract is sort of in one of the lower categories, okay, of saying it's got 3 to 5, okay? And you look at some of the units right next to it. These three right next to it are also in that same category of having 3 to 5. Sometimes these census tracts, not sometimes, a lot of times these census tracts are defined based on major roads, okay? And there is a major road that runs right up along that census tract here, okay? I forget the name of it, but you guys probably know what it is. But you can see it's almost like a lot of these, where's my cursor? So a lot of these dots probably fall on the wrong side of the street. When the census defines that boundary, it's probably getting pushed, more to here, and more to here. And those are all getting 3 to 5. And if you look at this census tract, it's got all of these right along the border, but still it's only being 3 to 5 because it's sort of that hard boundary of where I'm going to chop off, and you're either on this track or that track. So continuing on with this, so like I said, track borders are often along major roads, and retailers are often on major roads. Okay, and what this plot on the right-hand side is getting at is, it shows that 67% are within 100 meters of a track border. Not just that track, of all the tracks are within 100 meters of track borders, and 80% are within 200 meters. And you can kind of see that from the dot map, right? It looks like strings coming out from the Wilmington area because it's along major roadways, which is just how retailers are thought to be. But let's go back and see if we can improve this process somehow. Somehow, if we can share information across the tract boundaries, especially for ones that are really close to the tract boundaries. And we've seen the intensity before, right? It estimates the expected number of events per unit area. It's the heat map, okay? And remember the melted chocolate analogy. I promised you I'd come back to that. So what the idea here is to do is, well, let me melt that chocolate a little bit, okay, so I can get the mass of some dots shared across the boundary. And when I melt that a little bit, now let me chop up the census tract boundaries and count the intensity. Okay, so it may put a third of the dot on one track and 2/3 of the dot on the other track, just based on how close it is to that border. So that was the idea we came up with. We call it aggregated intensity. Here is the choropleth map that I showed you before with the dots. Here is now our estimated spatial intensity. Now this map, the one in the middle here, okay, that looks a lot different than this one over here. Okay, this one over here is designed to show spatial variation in risk, or spatial variation in the concentration of tobacco outlets. So I am smoothing that. I am putting that hairdryer over the chocolate enough to get it smoothed out so I can see these nice general trends. Here, I don't want to hold the hairdryer over that too much. Okay, we call that bandwidth smoothing, okay? I'm not going to smooth that too much, just enough for it to cross the borders, okay? And that's what you see here. So you can see the intensity is tightly around each piece of chocolate, each dot, okay? So when I do that, now chop up the intensity and add up the intensities, okay? And that's where we get to this map here. And you can now see that track that we isolated before, the ones just to the east of it, those three to the east of it, okay, still only have those small numbers between 3 and 5, which they should, but a lot of that information was right on the border, and it's shared now with this elongated track, okay? And now this one is accumulating more of that exposure like it should, and that's in the higher category of now of 9 to 14. So that was an impressive piece of work, again, led by Matty Brooks, and it was published last year in Spatial and Spatial Temporal Epidemiology. And like I said, the choropleth map has limitations. It ignores the variation within units. This new approach that we developed, aggregate intensity, allows us sharing across geographic boundaries, which could be important, especially in our tobacco research. Okay, I want to make sure I leave enough time for questions, so I'll go through these next few slides relatively quicker. There is another area of analysis that is often utilized a lot in spatial research, and that is called spatial cluster detection. Okay, this is where I'm looking for hot spots or cold spots. Okay, and unfortunately, there is very similarity between the words clustering, which we talked a little bit about before, that decay function gets at, and cluster detection. Okay, they mean two different things. Clustering is this idea that points just tend to be near other points, that idea of spatial dependence. Cluster detection is, well, I've got an isolated area, a hotspot of a lot of dots or a lot of points or a lot of whatever I'm measuring. There's methods available for both point level and spatially aggregated data. Here is one at the point level. This is now data on triple negative breast cancer cases taken from the Helen F. Graham Cancer Center and Research Institute between 2012 and 2020. We identified, or was identified for me, the cases, the 462 triple negative breast cancer cases, and then close to 3,000 non-triple negative breast cancer cases. Again, you can imagine the red and blue dots on the map. And we took that map of the red and blue dots and estimated that spatial odds, that ratio of intensities, okay, which gave us that non-parametric map or risk map of the risk of triple negative breast cancer. The same similar Monte Carlo random labeling scheme now allows us to take that map, which you see on the right-hand side, and identify areas with elevated risk, significantly elevated risk. Where on the map is that spatial odds significantly greater than 1, where I have more triple negative breast cancer cases compared to non-triple negative breast cancer cases. We'll call that hotspots. And then we can obviously look for significant areas where it's less than 1. That's what you see on the right-hand side. So we had, I think it was two cold spots, one in, I'm going to try to move everybody's picture here, one in northwest Newcastle County and one in North Wilmington, and then two hotspots, one obviously in Wilmington and then one in the Bear area. That is a way to look at hotspots. In this case, it's really, I would interpret it more as areas of elevated risk versus areas of decreased risk. That's one way to do this cluster detection. Another way is to use a program SATSCAN. People that are in the spatial field know SATSCAN really well. It's probably one of the most widely used pieces of software to do cluster detection. And it's a software that it's a model-based software. So we're assuming a distribution for our data. The software allows several different types of data and data settings. So we can talk about red and blue dots and look at the Bernoulli model. We can have cases and rates aggregated to area levels. We talk about Poisson. It's got normal, multinomial. I can do analysis at the point level or the spatial aggregate level. It does cluster detection in space, time, and also space-time. And since it's model-based, I can use more objective measures like likelihood ratio tests to help identify clusters. People who aren't familiar with this but are interested in this field, I would check out their website, satscan.org. It's a great website. It has a well-detailed manual tutorials, videos, and everything like that. Quickly, at the track level, what SATSCAN does, it searches for contiguous tracks, tracks that share a boundary, tracks that are next to each other, whose combined value, whatever we're looking at, whether it's a ratio of current to former smokers, whether it's a rate, it takes that combined value across those 4 or 5 census tracts, whatever it found, that is significantly different than elsewhere on the map. So it looks at what's going on inside a cluster compared to what's going on outside the cluster, and has Monte Carlo methods used to determine that significance. Another data set, and this is ongoing work I have with Alicia Salvatore and Pragya and Canal. And again, it's hospital-based admissions data. So we have close to 20,000 adult patients admitted between 2018 and 2019 at the 2 Christiana Care hospitals. We had 2 variables for this study. We had an Elixir comorbidity index, which is just counting the number of comorbidities. I think it was up to about 29. And then we also had EPA's environmental justice screen. This is an environmental risk index, and I give the website there for those who want to look up what it is. The EJ screen has information on environmental risk, social risk, and also they combine those two to get what they call cumulative risk. Okay, so we took the Elixir comorbidity and the environmental risk and we aggregated them both to the census tracts. And then instead of running a cluster detection just on one variable or just the other variable, we ran what's called a multivariate cluster detection. So we use SATSCAN, and SATSCAN has this as an option to look at, I want to know where there is anomalously high of variable 1 and anomalously high of variable 2. Okay, and this is the outcome that we got from that analysis. And this is what SATSCAN outcome looks like in general. It's identifying areas. These are areas of contiguous or next to each other census tracts where what's going on inside one of these areas is a lot different than what's going on outside. So with this study so far, and again, this is all work in progress, we identified 1 hotspot in the Wilmington area and 2 cold spots. Okay, and I just have down here that patients inside those hotspots, the one identified in Wilmington, had comorbidity burden about 20% higher than elsewhere on the map, and also an environmental risk score ranking that was 75% higher than those outside the map. So what's going on inside that Wilmington cluster is a lot different than what's going on outside. And then for the 2 cold spots, the 1 cold spot is mostly all of southern Newcastle County, the patients inside those cold spots had comorbidity burdens about 8 to 10% less, and environmental risk scores around 70% less than outside that cluster. That is an example of multivariate SATSCAN. You see SATSCAN used a lot in the literature. You see less of a multivariate SATSCAN. So we want, pushing the envelope a little bit, we wanted to do something more novel with these data. I apologize for going maybe a little longer than I wanted to. Here are some of our collaborative citations, and I'll just quickly get to the next slide. And thank you very much for listening and your attendance, and I'll be happy to answer any questions. And if you don't have time for questions, please look me up somewhere. I'm easy to find, and you can just send me an email. I'm happy to answer questions there as well. Thank you.
Thank you, Frank. We have maybe a minute or two if people have questions. There was a comment in the chat that line of your favorite census tract is actually 202 or the Concord Pike, which is where our Avenue North offices actually are located. Many of us familiar with that road.
Okay.
I just wanted to thank you for, really bringing, you're such a giant in this field, and you're able to really kind of bring these complex statistical and concepts and make them relatable and understandable. So thank you. And I think as there's many on this call that are work with our community health colleagues, and as we think about pushing, resources kind of outside the boundaries of our healthcare system into the community, it's so important to have in the back of our mind. I think that a map is more than just dots, and that the interpretation of data is so important, and it's more than just using what I think Leon Gordis used to call the eyeball method, right? We just don't want to kind of eyeball the map, but think critically about what it is we're looking at and and that it's more than just one variable, kind of thinking about how we use these things to look at multi-variables at the same time.
Well said. I agree.
Yeah, thank you. And it's great, and the partnership has been really great. I know Scott is, on the call, and Alicia, and many of us kind of within iReach and throughout Delaware that really have appreciated your expertise in guiding this work as we think about policies and where to put care within our community or where to put resources within our community. It really sort of guides that. So,
Yeah, perfect. I agree. Yeah.
yeah,
Like I said, it's probably one of my favorite collaborations to date.
thanks. There is a message from Scott that says it's been great working with Frank.
Yeah.
Agreed.
Likewise, Scott, and everybody else on the team.
It does give meaning for public health work. Thank you, Wendy. I'll kind of can I ask one question, just given your experience? So, as you do present this work, or in your experience in presenting this work to policymakers and people who are thinking about, resource allocation within the community, what has been kind of the most important piece of this work in the way that you communicate to a lay audience?
Yeah, by far it's the map, right? The map is everything. Everybody, regardless of your level of education or what you're educated in, it's the map that everybody can connect to. And in terms of my work, I go the other way and say the map is the hook. I want to hook people by the map and say, well, you know what? The map is limited. Although it looks great, and I'm sure somebody spent hours putting it together and making it look great, um, it's it's just a posting of your data. It's like a histogram or a scatter plot, right? And there's so much that we do in science and statistics beyond histograms and scatter plots, and let's apply that in the map as well. But when I'm trying to motivate a problem, I use the map. When I'm trying to explain the results, I map the results because that's what is. I mean, that's what's so neat about the spatial analysis area, that it's got a graphic that is just so powerful for everybody. And the Hopkins COVID dashboard, which I think originally was just recently just taken down, that is the best promoter of the field of spatial analysis that there ever will be. You saw how that map, which was just a simple posting of the data, how powerful that was to communicate to policymakers and everybody else in the world about COVID and the problems of COVID and where it's going, where it was yesterday, where it is today, and things like that. So definitely the map.
Awesome. Thanks, Frank. And next time, maybe we can talk about sort of spatial analytics. Spatiotemporal analytics. So kind of looking at changes through time, which I think is also
right. Everything changes in space and time, and the fields have been sort of historically, separated. You have longitudinal time series analysis, and you got spatial analysis. But bringing them together, there are definitely tools to do space-time analysis. They're not as nearly developed as the individual space tools are or temporal tools are, but the field is moving in that direction for sure.
Awesome. One more comment in the chat. Love the comparison of mapping to an Instagram post. Very spot on. It's a nice looking snapshot of your research. Thanks, Frank. Yeah, thank you. Thanks again for joining us this afternoon. It is a few minutes after 1, so we will wrap up. But thanks for your collaboration and continued collaboration as we work together in this field.
Definitely. And Mia, if anybody has further questions, wants to discuss more, just send them my way.
Will do.
Okay.
Thank you, Frank.
Thanks, everybody.
Enjoy your day.